Next speaker is Dr. Nishimura from Hyogo University. And he will talk about ultrasonography, its role for the diagnosis of HCC. Dr. Nishimura, please.
Thank you very much. Good afternoon, ladies and gentlemen. Thank you, Chairman, for making a chance for presentation. Today, I'd like to talk about the diagnosis of hepatocellular carcinoma using ultrasonography. Today, I would like to present you on the diagnosis of HCC by ultrasonography. First, diagnosis of HCC using ultrasonography, including sonozoid-enhanced CEUS. Second, guideline for the diagnosis of HCC focusing on ultrasonography according to APASL guideline, JSH guideline, Ali Matsui groups. And third, diagnosis of the malignant degree of HCCs. First, diagnosis of HCC using US, including sonozoid-enhanced CEUS. As we well know, the diagnosis of HCCs in ultrasound have specific findings in B-mode, Doppler, and sonozoid-enhanced CEUS. The typical B-mode imaging of HCCs are peripheral low echoic area, namely halo, peripheral acoustic shadow, nodule in nodule, and mosaic pattern. Next, basket pattern is characteristic in the Doppler imaging. The lower ultrasound image suggests non-enhanced SMI. Here, I would like to present you about SMI. This slide shows SMI image. Left picture is a color SMI image, and right picture is a monochrome SMI. As you can find, this displays micro vessels with low flow velocity, but artifacts are minimized. This monochrome SMI image clearly depicted new micro vessels. While in this classical HCC cases, conventional color Doppler and flow power Doppler have limitation to detect blood flow, even in hypervascular HCCs. This is a case of HCC with HCV liver cirrhosis. As you can see, tumor microvessels can be identified by non-contrast enhanced SMI technology. In sonozoid-enhanced CEUS, hypervascularity with washout and hypointensity in the Kupffer phase can be identified in the typical HCC findings. Second, guidelines for the diagnosis of HCCs, APASL, JSH, and Ali Matsui group are summarized. The role of ultrasonography in APASL HCC guideline is presented as follows. Ultrasonography is a screening test and not a diagnostic test for confirmation. Second, contrast-enhanced US is useful for characterization of US detected liver nodule and is as sensitive as dynamic CT or dynamic MRI in the diagnosis of HCCs. The diagnostic algorithm for HCCs is presented as follows. First, typical HCC can be diagnosed by image regardless of its size if a typical vascular pattern is obtained on dynamic CT, dynamic MRI, or CEUS. Second, nodal regions that show a typical imaging pattern should undergo further examination. Third, EOB MRI can detect the earliest initial change of HCC, including high-grade dysplasia nodule and early HCCs. This figure suggests a flowchart for the diagnosis of HCCs. The role of ultrasonography is primarily the detection of nodules, followed by the surveillance examination every 6 months and detailed examination using sonozoid-enhanced CEUS for nodules with atypical imaging. This figure shows the flowchart for the diagnosis of HCCs in Japan Society of Hepatology 2017. The role of ultrasonography is similar to APASL guideline. Primarily, the detection of nodules, followed by the surveillance examination and detailed examination using sonar-enhanced CEUS for nodule with atypical imaging. This is a diagnostic algorithm for HCC proposed by Professor Ali and Professor Matsui group in the Ministry of Health. In the study by Professor Matsui group, they found that diagnostic accuracies of dynamic CT and MRI in detecting hypervascular HCC were similar. So they chose not CT, but dynamic CT MRI as the first procedure for the tumor evaluation. The procedures afterwards follow the same way as in the previous algorithm for hypervascular cases. But for hypervascular cases, the next procedure is evaluation using EOV MRI of hepatobiliary phase. And if the signal is hyperintensity, sonar-enhanced ultrasonography is recommended. When sonar imaging reveals hypervascular or a defect in the Kupffer phase, the diagnosis is HCC, and without performing biopsy, appropriate treatment for HCC would be carried out. When either hypervascular or defect is not observed and the size of tumor range from about 1 to 1.5 centimeter, tumor biopsy is recommended. If the tumor is less than 1 centimeter, follow-up observation will be carried out. To conclude, the role of US in diagnosis HCC are the same role among every diagnostic algorithm. Now, we examine the diagnostic validity of APASL guideline for HCC using our own data. The target nodule were 2,185 nodules diagnosed as HCC histopathologically. 192 out of 285 nodules, 67.4% were hypervascular with washout and diagnosed as typical HCCs. 26 out of 2,185 nodules, 9.1%, were hypervascular without washout. 18 out of 26 nodules were hyperintense on the hepatobiliary phase and diagnosed as typical HCCs. 8 out of 26 nodules were hyperintense on the hepatobiliary phase. CEUS were performed for these 8 nodules. 6 out of 8 nodules were hypervascular, and 2 out of 8 nodules were isovascular on the arterial phase, but all of 8 nodules were hyperintensity in the Kupffer phase and diagnosed as HCCs. Finally, 2,118 nodules with hypervascular by EOB MRI were all diagnosed as HCCs. This is a typical imaging of 33 mm HCC located in segment 5 by EOB MRI and CEUS. In the dynamic study of EOB MRI, this nodule was detected as hypervascular nodule without washout and ice intensity on the hepatobiliary phase. On the other hand, this nodule was identified as hypervascular nodule on the arterial phase with partial washout and hyperintensity in the Kupffer phase in CEUS. Accordingly, this nodule was diagnosed as HCC. The above results suggest that the hypervascular nodule without washout and iso or hyperintense on the hepatobiliary phase can be diagnosed as HCC by CEUS. Third, I would like to talk about the diagnosis of malignant degrees of HCCs. In RFA therapy, for HCC, it is important to assess hepatic function, child A or B, and tumor factor including tumor number and tumor size. Additionally, the degree of malignant grade for HCC can be an essential factor in allogeneic therapy, because as the degree of malignant grade of HCCs worsened, higher incidence of HCC recurrence was reported. As a diagnosis for the degree of malignant grade of HCC by ultrasound, I would like to talk about morphological diagnosis and the degree of tumor differentiation. Morphological diagnosis of HCC can be done by microscopic classification and imaging characteristics of tumors' borders. As you well know, it is difficult to distinguish between so-called borderline lesions and well-differentiated HCC in small nodule with distinct margin type. On the other hand, it is easier to reach the diagnosis in simple nodule type with clear margin. However, in cases with extranodular and infiltrative type, an accurate tumor diagnosis may be essential as the tumor can be malignant enough to affect treatment strategies. Kupffer imaging of HCC may be useful for the morphological diagnosis. In the upper figure, this tumor is clearly demarcated in B-mode US image, but is irregular in CEUS image. This node was 20 mm, but was performed by surgical treatment because its morphology. In the lower figure, morphology of HCC was confluent multinodular type in Kupffer phase imaging, but unclear in B-mode US. These images show the classification of tumor vessels. Left figure is fine pattern. Tumor vessels are not clearly visualized, and only fine vessels are visualized. Middle figure is vascular pattern. Tumor vessels are visualized more clearly than fine pattern. Right figure is irregular pattern. Tumor vessels are thick and straight. As you can see, combining blood flow images and the findings in Kupffer phase enable to stratify degree of tumor differentiation. That is, cases with a defect and irregular vessels will be mostly poorly differentiated HCCs, while cases with fine vessels and ISO intensity in Kupffer phase tend to be well-differentiated HCCs. Here we will review multi-step hepatocalcinosis and change of intranodular blood supply in CTHA and CTAP. This report is reported by Dr. Matsui. Intranodular portal supply gradually decreases in accordance with the worsening of tumor differentiation, and finally disappears in moderately differentiated HCCs. On the other hand, arterial blood supply first decreases in the early stage of hepatocalcinosis and then rapidly increases. And finally, the entire nodule is supplied only by artery in moderately differentiated HCCs. This nodule was 11 mm nodule located in segment 5/6. In dynamic study of EOB MRI, this nodule had low intensity on the hepatobiliary phase. The dynamic study of EOB MRI, this nodule had isovascular on the arterial phase, and low intensity on the hepatobiliary phase. In CEUS, this nodule was detected as hypovascular nodule on the arterial phase with iso intensity in Kupffer phase. Accordingly, this nodule was diagnosed as dysplastic nodules. In conclusion, non-enhanced SMI, which improved its sensitivity to minute vessels with low velocity, visualize micro-vessel flow in tumors. Sonodally enhanced ultrasonography is very useful in diagnosing hypervascular nodules, which are hyperintensity on the hepatobiliary phase without washout, malignant degree of HCC, and dysplastic nodule. Thank you very much for your attention. I would like to close this presentation.
Thank you, Dr. Nishimura. Thank you for your. There are lots of beautiful imaging pictures in your presentation. Any comment or please?
Thank you very much for your excellent talk. Since CEUS is better than conventional US, and the Barcelona group suggests only CT or MI can diagnose the HCC without liver biopsy. Do you suggest that can CEUS replace the role of CT or MRI, especially for those whose renal function is not very good? Can CEUS replace the role of CT or MRI? The second question is, since CEUS can see more clearly of the nodule type, as you said, a simple nodule or nodule with extra nodule or confluent type, do you suggest for all the patients with conventional who find a tumor, and you suggest all the patients should do CEUS? Thank you.
In our hospital, almost all patients perform the CEUS, but according to tumor size, or more than 20 millimeter, I think I recommend us perform CEUS, I think.
Yes. If you do CEUS, do you still refer the patient to do CT or MRI?
In our hospital, EOB MRI performed for secondary procedures. Almost all tumors were performed EOB MRI and CEUS.
Okay, thank you.
Question? You mentioned that sonozoid imaging is useful for estimating the degree of tumor differentiation, but how accurate is this method in terms of tumor differentiation? Do you have any definite value, such as sensitivity or specificity?
Sorry, I have no data on the sensitivity and the specificity, but fine pattern is most well differentiated calcium HCC, and irregular pattern is very differentiated HCC. So we think so. Diagnosis of HCC.
And
thank you very much, sir. Do you do CT scan on all nodules you see in the liver? And sometimes it's
CT scan.
Yes, because you said ultrasound and nodule on ultrasound and then CT scan. Are there specific characteristics in the ultrasound that will warrant you to go to the next step? Because in a resource-limited country, that's quite difficult to do always a CT scan. So when would you say you would do a CT scan on seeing a nodule by ultrasound? Do you do it in all patients that you see a nodule on ultrasound?
We perform CEUS for all nodules, but CT scan was performed not all nodules. So
only if it's confirmed by sono imaging.
Yes.
And can you use conscious enhanced ultrasound as an assessment of the amount of ablation you've done in your patient? When you ablate the tumor, and then can you use real-time conscious enhanced ultrasound to assess if you have actually totally ablated the tumor?
Yes. Okay. I performed almost of CEUS utility, and after CEUS, and we performed EOG-MRI first line, and CT sometimes we use diagnosis of HCCs.
So in the near future, do you feel that the guidelines, I mean the HCC diagnostics algorithm, may need to be changed, and contrast enhanced US should be involved more often?
I wish so.
You hope so?
Yes.
Okay. If not, thank you very much, Dr. Nishimura.